Neurology quiz number 48. Describe the various disease-modifying therapies used in multiple sclerosis, part 2 of 3. Continuing discussion on oral agents from quiz number 47. Number 3, sphingosine 1-phosphate receptor or S1PR modulators. S1PRs are expressed throughout the body. They regulate lymphocyte trafficking, brain and cardiac development, vascular mobility and bronchial tone. Subtype 1 has a key role in immune cell trafficking, vascular tone and heart rate regulation. Subtype 2 is involved in mast cell degranulation and histamine release. Subtype 3 is involved in heart rate regulation. Subtype 4 is expressed predominantly on immune cells and airway smooth muscle cells. Subtype 5 is expressed primarily in CNS white matter tracts by oligodendrocytes and also regulates natural killer cell trafficking. Fingolimod or Gilenya was approved in 2010 and was the first oral DMT. It modulates receptor subtypes 1, 3, 4, and 5. It reduced the annualized relapse rate by 50%. Dose is 0.5 milligrams POQ day. Siponimod or Mayzent was approved in 2019. It selectively modulates receptor subtypes 1 and 5. Dose is 2 milligrams POQ day. Ozanimod or Zeposia also selectively modulates receptor subtypes 1 and 5. It was approved in 2021. It is converted into an active metabolite with a long half-life of 30 days. Dose is 0.92 milligrams POQ day. Ponesimod or Ponvory is a selective receptor subtype 1 modulator approved in 2021. It has a short half-life. Dose is 20 milligrams POQ day. These medications are approved for RRMS, active SPMS, and CIS. Mechanism of action. These drugs downmodulate the S1PR on lymphocytes, resulting in functional antagonism that inhibits lymphocyte exit from secondary lymphoid tissues. There is reduction in lymphocyte trafficking into the CNS due to sequestration of otherwise intact lymphocytes in lymphoid tissue. They also cross the blood-brain barrier into the CNS, and expression of S1PRs on several cell populations in the CNS suggests that direct CNS effects can also contribute to the therapeutic effect. Side effects. Fingolimod requires monitoring of first dose because of risk of bradycardia. Baseline EKG is obtained and patient observed for bradycardia for 6 hours after the first dose with heart rate and blood pressure measurement every hour. If heart rate falls below 45, patient should be monitored till this resolves. Symptomatic bradycardia requires continuous EKG monitoring till resolution. If this requires pharmacological treatment, monitoring needs to be repeated for the second dose. All the drugs in this class are contraindicated in patients with Mobius type 2 or third degree AV block or sick sinus syndrome without a pacemaker. They are also contraindicated in patients with decompensated heart failure and those patients who have had unstable angina, MI, TIA, or stroke within the last 6 months. An EKG should be done before prescribing any of these medications. Impairment of pulmonary function tests can occur, but this is clinically meaningful only in patients with severe baseline pulmonary dysfunction, and patients with a history of asthma or COPD may require a pulmonary evaluation. Monitoring for macular edema is needed, especially in the first year of treatment. Patients who have diabetes are at increased risk. Macular edema is reversible on discontinuation of the medication. Risk of infection is increased with all these agents, and patients should be monitored for infections including PML and fungal infections such as Cryptococcus. Patients should be vaccinated against VZV prior to initiating these agents. Other side effects include risk of rebound disease activity after discontinuing the medication, PRES, and increased risk of cutaneous malignancy. These medications are contraindicated during pregnancy. Live vaccines are contraindicated in patients on these medications. Data shows that vaccinations are less effective in patients taking these drugs. Those agents with short half-lives such as Siponimod or Ponesimod can be stopped 1 to 2 weeks before vaccination and then resumed 2 weeks later. Number 4, cladribine or Mavenclad. This drug was approved by the FDA in 2019. Dose is 3.5 milligrams per kilogram given PO. It is given in 2 treatment courses. Each course is 1.75 milligrams per kilogram, which is divided into 2 treatment cycles of 4 to 5 days each, given 23 to 27 days apart. The interval between 2 treatment courses should be at least 43 weeks. It reduces annualized relapse rate by 58%. Mechanism of action: it impairs DNA synthesis, and its most likely mechanism of action is by its cytotoxic effect on B and T lymphocytes. Its peak action on lymphocytes occurs 2 to 3 months after the start of each treatment cycle. It is approved for RRMS and active SPMS. It is generally indicated only when there is a suboptimal response to other DMTs. Prior to administration, testing is indicated to exclude active or latent HIV, TB, hepatitis B and C. VZV vaccination should be given to patients who are antibody negative. Common side effects include lymphopenia, neutropenia, skin rash, alopecia, and herpes infections. Most serious side effects include opportunistic infections. Treatment can increase risk of malignancy, and it should not be given in patients with an active malignancy. It is contraindicated in pregnancy and lactation. Live vaccines should be given at least 4 weeks before treatment is initiated and are contraindicated during treatment. Studies have shown that it does not reduce antibody response to inactivated vaccines.